Hi, everyone. Good morning, good afternoon, and good evening for some of you who are joining us from the other side of the world. Thank you once again for joining us today in the second series of our webinar on speed up and scale up TB testing. For those of you who joined the first webinar, this second webinar is going to focus on which test and where, very specifically talking about the Asia Pacific region in terms of the TB diagnostics. This study club or webinar is part of a preparatory sessions in the lead up to the TB diagnostics meeting that will be held in Hanoi in April. And the purpose of this study club or webinar is to bring together community and civil society members, raise awareness and build literacy on TB diagnostics with the overall goal to foster robust and informed engagement and advocacy, both for planning and as well as to continue to push for the scale up of TB diagnostic packages as part of the National Diagnostic Network at the country level. So for those of you who have joined us, on behalf of APCASO, DEC, and TAG, would like to warmly welcome you to our webinar today. My name is Mangala. I'm a program officer with APCASO, one of the co-organizers of this webinar. I now call on Tapiva, who's the director of the Pan-African Treatment Access Movement, PATAM, who will just give you a very short overview on the three organizing partners of this webinar. Over to you, Tapiva.
Thank you, Mangala, and morning, afternoon, and good evening to everyone on this webinar. Thanks for joining. So I'm gonna introduce the three co-sponsors to this webinar. The first co-sponsor is APCASO, which is an Asia Pacific Regional Civil Society Network organization that serves as a catalytic platform for advocacy and community system strengthening for health, social justice, and human rights for key and vulnerable and marginalized communities in the Asia and Pacific regions. Their work focuses on HIV, TB, malaria, and broader health issues, amongst others. The second one is the DEC, the Diagnostics Equity Consortium. This is a civil society effort to support and catalyze advocacy for equitable access to diagnostics across health challenges in low and middle income countries. It is hosted by two organizations. The first one is the Pan-African Treatment Access Movement, which I work for, and the Center for Global Health Policy and Politics, which is based at Georgetown University's O'Neill Institute and School of Health. And the third one is TAG, Treatment Action Group, which is an independent activist and community-based. Sorry, can you just go back, Alice? So TAG is an independent activist and community-based research and policy think tank based in New York City, fighting to end HIV, TB, and hepatitis C virus. The organization also works to track and accelerate TB research and development and access to innovations. This work includes advocacy to support the development of TB screening and diagnostic. Sorry, just a minute. And diagnostic technologies, and to improve access to TB diagnosis and care. So thank you, and over to you, Mangala.
Thank you. Thank you so much, Tapiva. Once again, on behalf of all the three organizing partners, APCASO, DEC, and TAG, we welcome you to this space. I just want to remind you that this is a space that we hope will be one that will allow for the civil society and others in the call to learn from each other, but also to share knowledge, because one of the things that we have realized is the fact that TB diagnostics still remains in a space where there's a huge gap between the research world, the practitioner world, and the civil society. So one of our main objective for this webinar and the subsequent plans we have is to bridge that gap and to increase the literacy around diagnostics. So how we have designed this webinar is that we will have a panel of three speakers who will share with you some of the latest information around TB testing and also their experiences and the context in countries in the Asia Pacific region followed by a discussion where you would have the opportunity to ask questions. There will, of course, be an opportunity for Q&A towards the end of the webinar. As speakers are presenting, please feel free to send your questions and thoughts via the Q&A feature at the bottom of your Zoom interface. During the Q&A session, you will also have the opportunity to raise your hand and come off mute to ask your questions live. Again, this is sort of a platform for us to learn from each other, where we are also eager to learn from you some additional information that you might want to share with us on the country context of the issues that we will be discussing today. So I do hope that we will approach this webinar with that spirit of learning and exchanging information, and together increasing our understanding and literacy around TB diagnostics. Moving on, we have our first speaker who will help us sort of to set the stage around the issue of, or the question of, which test and where. Dr. Grania Bridgen, who is the Senior TB Advisor at the Global Fund, will talk to us about this, as well as to share with us some information around the Global Fund strategic initiative to support TB diagnostics for the region and beyond. Over to you, Dr. Grania.
Thank you, Mangala, and welcome everybody. So yes, the next slide. So I think sort of what we're talking about today is which test where. And in last week's webinar, or the first webinar in this study club, there was an overview of some of the current tests and some of the tests coming. And I think sort of from a Global Fund perspective, we see TB diagnostics as really kind of the first, well, a key part of making sure that we find, accurately diagnose and successfully treat everyone with TB. And as such, it represents really a significant part of our investments in TB. So in the current grants cycle that Global Fund is working and supporting countries, we're investing $600 million US dollars in TB screening, diagnosis and susceptibility testing, which is approximately 25% of our current investment in TB. And with 50% of this investment really going towards all the various health equipments, the tests, and the service and maintenance costs for the molecular diagnostics. Next step. The next slide. But the other thing that we are increasingly supporting is the systems in which these tests sit. And I think this is kind of, these are sometimes known as diagnostic network optimization, diagnostic network assessments, but really the sense of kind of where are these tests in the right place? So the which test and where question that this webinar today is asking us, because we have TB tests, but they sit within a lab infrastructure. And many of our tests, as you heard last week, test for more than just TB. So a lot of our low complexity NAT tests do TB, they do HIV, they've done COVID, they've done and sort of a number of other tests. And then some of our more newer, high throughput, complicated systems like targeted next-gen sequencings also have a sort of capacity to work for other diseases. So looking at what the whole diagnostic network, so kind of what tests sit outside the TB program but can support the TB program, what tests can other programs support the TB program to their service and maintenance, or an integrated sample transportation, because we don't have a near point of care or a point of care test yet for TB. So we're very reliant upon how can we make sure we're transporting samples to test rather than people to tests. And so this all kind of requires a knowledge of what tests are where, and then how to get people to have access to those tests. And so kind of knowing your diagnostic network helps break down the silos between the disease programs, and most importantly, I think, increasing accessibility for testing. And as you can see, this this investment in the systems around the labs have been increasing over the last 3 cycles of the Global Fund. So recognizing we're not just procuring tests, but we want to make sure that the systems that these tests go into are strong. Next slide. And so, hopefully we'll have the next slide. And so what does kind of knowing your diagnostic network mean? So I will just wait for the slide to flip. I can maybe start talking to it in the meantime. Sorry about this. So what does this kind of network knowledge and decision making sort of help us do? So the slide will come in a moment, but it kind of helps this long-term investment in the lab's system. So, and it can provide sort of immediately practical outputs, such as kind of what tests have spare, what tests and what devices and platforms have spare capacity. Are they in the right place? What's the most effective sample transportation routes? If there are devices with a lot of spare capacity, can they move to a new lab? Is there a gap where potentially thinking of investing in building a new lab may be appropriate? And sort of, but then, and what I'll come to now is also, as we are entering, as you saw in the first webinar of this study club, we are entering a period of really, potentially really very exciting innovations in TB diagnostics with additional low complexity NAT platforms. But I think also what's really potentially the most exciting thing is an entirely new class for TB diagnostics, this near point of care test. And knowing where your current devices are, what the gaps are, what the challenges are, will really help countries and programs kind of think strategically about new tools and where they go and what's the best way that they're used for the national program. What are the national challenges? What are the national gaps? Or even the sub-regional gaps where that's where maybe a low complexity NAT is needed, or where we need something more decentralizable, the sort of the near point of care test. And so really kind of knowing your network is good for now, but it's also really good for helping us think about new tools, because in TB, we've kind of only had one regimen, one test. We just have to implement it all, but we're in this really exciting phase of we're going into choice where we have a number of tests and really thinking about there's not going to be a one-size-fits-all approach. So knowing your network will make sure that you're getting the maximum impact from the diagnostic tools that are available out there. The next slide. And so this kind of fits into what we're thinking around for country readiness for the new tools. So as you heard last on the Study Club 1, there's a number of kind of new tools coming. There's the next generation true point of care test, urinary LAM. This looks like it's going to be end of 2026 at the earliest. We have the low complexity NAT platforms, which are similar to the Expert and TrueNAT, that kind of system. These are multi-disease platforms, but they kind of still need quite a strong lab infrastructure. And the WHO last year broadened their guidance such that it's now a class, and there's a number of products that may be going for the Global Fund ERP or the quality assurance process to enable procurement from the Global Fund perspective in the next sort of 6 to 12 months. But I think, as you heard the last time, the really exciting new class, new way of thinking about TB are these near point of care tests, and that these can either be used in sputum samples, but also excitingly expanding us outside that into tongue swabs. So, but they're kind of very robust. They're usually battery operated. They can be decentralized. They, at the moment are kind of TB, not TB. So we haven't got the drug sensitivity testing component. And that's why knowing your network, so knowing where the nearest test to ensure that we have a full, accurate diagnosis is key to thinking about how we implement these kind of new class of tools. Next slide. And kind of the way we're thinking about it in Global Fund, and I'd really like to hear everyone's thoughts on this, both now and in the meeting in Vietnam, is that kind of as these new tools come in, there's a number of ways we can use them. So they're going to be a lot cheaper than the larger platforms. And so we sort of really hope that this will allow for, as the target product profile was saying, kind of a platform cost of around $500 and a test cost of less than $5. So really breaking up the current cost structures we have when we think about TB diagnostics. So they could just be used to contain the costs. So kind of have that as our first diagnostic test. And then you do the expert or TrueNat or the low complexity NAT as your reflex test. But they sit within the existing lab infrastructure. Then there's the kind of, can we go bigger than that? Is that the main issue in your national context? Or is there still that gap of, are we giving 100% of people a low complex molecular test as their first test? Or are we still relying on diagnostic microscopy? Because then it's like, could they sit by your microscope? So knowing where your microscopes are, knowing the burden, how many TB tests are they doing? And then this could sort of rapidly help us achieve the UN HLM target. And there we hope there's existing infrastructure with regards to sort of people with some lab training, sample referral systems, treatment and initiation. And then there's the bold and kind of maximizing these new tests to their maximum potential where they can sit in the PHC. And that's kind of, you know, so knowing your network will help you choose which test is where. So at a PHC, we don't currently have a TB test that can sit at the primary healthcare level, but we do have a microscope and we do have lab infrastructure, but we're going to have a new test that can come in and think about doing all three. So that's the kind of key of knowing your diagnostic network so that you know which test goes where. Next slide. And just sort of to reiterate that from the Global Fund perspective, we are thinking holistically across the whole lab infrastructure. So where tests can offer more than one disease, we have a preference for that so that we're strengthening the whole lab system rather than just the TB lab system. And then that also will help national programs to really kind of strengthen their whole diagnostic infrastructure, utilizing our investments. And then also we continue to work with partners to really kind of think about how we can continue to improve the access, the pricing, the service and maintenance. And I think one of the key areas of this is the sort of looking in the pipeline and seeing how we can work with partners to ensure that countries get the most accessible terms for any new tools. Next slide. So looking forward to putting your comments and questions in the chat about sort of how to think about diagnostic tests. We want to continue these conversations at the workshop coming up in Hanoi at the beginning of April, and really bringing together, as this webinar is, all the key stakeholders. So the National TB Programme, the National Lab Programme, and the civil society organisations, because I think to really maximise the input of any current and new diagnostic tests, we all have to work together on this. Thank you very much.
Thank you. Thank you so much, Grania, for that very informative session. Once again, these are such important information to be sharing with all of us, because if we are going to be working together, then it's so important to ensure that everybody's on the same page as far as the information is concerned. And as we prepare for the Hanoi meeting, we're trying to ensure that that happens, whether, to push for the civil society advocacy, but also to have the other stakeholders to be on board with what we want. Because at the end of the day, the vision is the same. We just need to figure out what is the best way forward. And I think in today's climate, it is so important for us to ensure that our efforts are aligned in order to maximize the output. And on that note, I am going to call on our next speaker, Teju, who will take us through, who is the TB project associate at the Treatment Action Group, TAG, whose presentation will cover the trade-offs and consideration for point of care testing, and what does that mean for us as we push for it at the country levels. Over to you, Teju.
Thanks, Mangala. Hi everyone. Thank you for having me here. As Mangala said, as we're moving forward with these new exciting tools in the pipeline, I'm going to be covering a few of the trade-offs and considerations that we need to keep in mind with using tests that have alternate sample types, and also considering where these tests could be placed. Next slide, please. So you already heard about this from the first webinar, but I just wanted to do a little refresher on it. But the WHO standard comprises of 12 benchmarks that are to be computed by countries in the 4 steps of the diagnostic cascade. So you can see the 4 steps over here and the 12 benchmarks laid out under them, but I wanted to draw your attention to 3 specific things over here. So with accessing tests, one of the things that the WHO calls for is WHO recommended rapid diagnostics access in primary healthcare center, the provision of universal drug sensitivity testing, and timely delivery of results. So while we look at these new tools in the pipeline, a few of the things that we need to keep in mind for evaluating them is, one, placement, if they have the ability to test for drug sensitivity, time to result, which in turn means treatment initiation and how quickly that could be done. Next slide, please. So again, while Grania did mention that a lot of these tools are near point of care, and this is an exciting new class of tools in the pipeline. Again, this is something that was mentioned in the first webinar, but just as a highlight, as a reminder, this is what point of care, near point of care, and low complexity actually mean in terms of equipment, infrastructure, and HR skill levels. So while we talk about near point of care, they are mostly battery operated in terms of equipment required, don't necessarily need too much infrastructure in terms of the labs that they're placed at. And with HR skill levels require basic technical skills, so basic pipetting and not necessarily critical precision. These are different from true point of care tests, which require no equipment, no infrastructure, and none or minimal skills, which could be ideally a self-test or a self-sampling test. But this is what we need to keep in mind with what's needed for near point of care tests. Next slide, please. So coming to tongue swab-based near point of care TB tests, several companies are developing rapid molecular diagnostics for TB detection, and these are using small and fast testing instruments, and these are designed to be implemented at the point of care in the community and primary care facilities. And one of the biggest contributions of such tests is that they could enable same-day testing, diagnosis, and treatment initiation. But one thing that, again, we need to keep in mind while we talk about diagnostic accuracy is that tongue swab samples are expected to be less sensitive than sputum samples. So while we're having a sensitivity of about 70% with tongue swab samples, sputum samples usually give us about 90% sensitive tests or more. But the benefit of this is that nearly everyone can easily provide a tongue swab sample, and more people will be able to receive a diagnosis. I think we're all very aware of the limitations with sputum, and a lot of people who are sputum scarce are not able to provide sputum easily, and how that's a big barrier to testing. So this tongue swab based samples kind of overcomes that gap in TB diagnosis. But another thing, as again Grania mentioned, is that these tests are only yes or no TB tests. So they only detect TB, but as per the WHO standard, they don't necessarily provide DST or tell you your resistance to the treatments that you're going to be on. So they will need to be linked, and you need further testing for drug resistance. And ideally, this would be using near point of care molecular DSTs. Next slide, please. So I can just go on while I wait for the next slide. But while we're talking about this, the main trade-off that we're thinking about with these tests is if we're willing to trade accuracy for access. So to address gaps in the cascade of care, we need to make tests more accessible, and accessibility or more accessible tests enable more frequent and widespread testing. And this could also increase the diagnostic yield, which is a metric to measure the performance of the test, similar to diagnostic accuracy. So it's the proportion of people who are identified with a disease using a diagnostic test out of the total number of people who are eligible to be tested. And in order to increase the diagnostic yield, we need tests to be available closer to the point of care, require accessible sample types, and however, both of these can affect test accuracy. So the main question that we're kind of grappling with over here is if a less sensitive test is acceptable, if more people are able to access it. Next slide, please. And this is empirical evidence from a modeling study that kind of looks at the question that was just posed. So it looks at point of care TB tests with minimum sensitivities of 70% and non-sputum samples for non-sputum samples and 78% for sputum samples. The study found that these could achieve comparable or better case detection rates than current standards of care. This modeling study was, or results or evidence from this study was used to inform the WHO target product profile. And the models or the assumptions built into the model is that the current standards of care was evaluated in 3 countries. So that's Kenya, South Africa, and India. And in Kenya, it's expert or smear microscopy. In South Africa, it's the 4-symptom screening and expert confirmatory testing. And in India, it's the expert or TrueNAT smear microscopy and clinical diagnosis. So given these current standards of care, if we have minimum sensitivities of 70% or 78%, we could still achieve the same level of case detection or even better, perhaps. Next slide, please. So this again is from the same modeling study, and it's a graphic demonstration of these trade-offs that we're talking about. So it shows you the potential benefits of having a less sensitive test that more people can provide samples for. So if you see the graph on the right, the smaller blue square shows you 25% of our access rate. Is the number of people who are able to provide samples. So think of this as maybe like a sputum based tests, and a fewer number of people are able to provide samples and access these tests. So in this small group, it's extremely accurate. So it has a higher accuracy, but in a very small groups. Only the smaller blue box are people who are able to provide samples. So just to keep in mind that the high rate of accuracy is in a very small group. But if you look at the graph on the left, you see a bigger blue square. So this probably is a test with a more accessible sample type, such as an oral swab or a urine test, which a lot of people can provide these samples, but it's less sensitive. So you see that it has a lower sensitivity and lower accuracy rate, but still a lot of people are able to, many more people are able to get diagnosed through this test. So when you think about these kinds of tests, and if you ask people what they want, and if you're kind of taking a preference survey, people would say that they want a faster test or a more accurate test. But if you give end users and national TB programs these considerations and these trade-offs. This is the kind of information we need to have to know which one you would choose. Again, I just want to put in the caveat over here that this is a hypothetical modeling-based scenario, but we need to test these out in practice and kind of collect data on diagnostic yield to know if this holds up in real world. Next slide, please. So while we're talking about alternate sample types that have lower accuracy, I also just wanted to highlight two different kinds of tests that have more accessible sample types, but have proven benefits despite lower accuracy. So stool samples for children are less sensitive, so it's about 50 to 67% of accuracy, but it's proven to increase yield. So in practice, NTPs in high burden countries are already implementing stool-based testing as the first test for children with presumptive TB. And in Nigeria, they found a 4.8% yield from stool-based testing compared to 3.5% from a sputum-based test. And a study in Ukraine found a high concordance of test results between stool and respiratory samples. So this is about 81% of concordance between these test results. And the urine samples for people living with HIV, Abbott's Determine TB LAM is, again, as we know, a low sensitivity test with sensitivity only ranging from 35 to 42%. But again, this is a group that's that's usually vulnerable with TB diagnostics and not being able to provide accurate or spontaneous sputum samples. So this urine LAM test, despite its low accuracy, is proven to have mortality benefits and reduce mortality by 15% among people with advanced HIV disease. And what this test kind of does is it highlights the importance of early detection and treatment initiation. So despite lower accuracy, there's many benefits that go across the different parts of the care cascade. Next slide, please. So this is just some preliminary results from accuracy of oral swab testing for pulmonary TB. Again, Morten presented some of this in the first webinar, but this is for the first two tests are PlusLife and TrueNat, and this is based on accuracy data that was presented at the Union conference from R2D2 studies. So you can see that the sensitivity for PlusLife is about 88.5%, and for TrueNat about 77.5%. So these still meet the WHO target product profiles, but are definitely lower than sputum-based samples. But these are oral swabs that are being collected. And as Grania mentioned, you can see that the price is lower than what the current testing is going for. And there's also the Expert MTB RIF Ultra, which is which has about 74% sensitivity. While Sputum Expert Ultra is the reference standard for these studies, it's also important to know that there's other developers entering the market, which is a good thing, because to overcome the long-standing monopoly that we've had in this field of TB diagnostics. But again, with accuracy in children, I wanted to highlight that children could most benefit from oral swabs because they do struggle with sputum, but unfortunately we see that we still have lower sensitivity of these tests in children. This is from a systematic review that shows you that sensitivity is ranging from 5% to 42%, which is fairly low. But again, I just wanted to put out a reminder that stool sensitivity is about 50 to 67%, but is still recommended by the WHO. So while we don't have too much going on in this space, something is still better than nothing. So if we're dealing with the upper end of this being 42%, then we kind of have to make do with what we have until we have something better for this vulnerable population. Next slide, please. Switching from accessibility of sample types, I wanted to move to the proximity to point of care and where these tests are placed. This is results from two large-scale clinical trials, the EXPEL TB and TB CAP study, which shows you that providing rapid molecular TB testing at the point of care in high-burden countries leads to faster diagnosis, quicker treatment initiation, reduced patient loss to follow-up, and increased overall TB case detection as compared to centralized testing. The Expel TB had the intervention strategy of placing molecular tests at community health centers, and this led to a 56% higher rate of treatment for confirmed TB within 14 days compared to routine care. And TB-CAP looked at implementing the MolBio TrueNAT test in primary care settings, and this resulted in 82.9% of people with TB diagnosed and started on treatment on the same day that they presented to care, and 98% started on treatment within 7 days of presenting to care. So you can see immediately the results having faster diagnosis and quicker treatment initiation. Next slide, please. And one thing I wanted to, again, talking about the DST considerations over here, we are, with the accessible sample types, we're trying to close the gap of people who can't produce sputum and have more accessible sample types. But while we're trying to get rid of sputum, we can't do with it right now, I also wanted to highlight that we're not yet ready to get to a place where we don't rely on sputum at all. We can't do without it right now as well. We're continuing to rely on sputum for DST and testing resistance profiles, as well as treatment monitoring. So while we need universal DST, and this is something that the WHO standard calls for, we can ask the question of, does it all need to be in one test? So over here, I'm talking about a reflex testing algorithm where for the first step, you're screening at the point of care using accessible sample types. And step 2, you're linking that to further diagnostic testing at the near point of care, which is including DST. However, a few considerations with this algorithm is that it's mostly justifiable in low drug-resistant TB prevalence settings, but ideally it would reduce burden on on the healthcare system because you're not doing a DST for every person coming in. You're also reducing loss to follow-up and same-day treatment initiation, but this algorithm would work with a good transport system and good monitoring and evaluation. And again, I wanted to highlight over here the importance of community and end-user literacy and the important work of outreach of community-based organizations for having an algorithm like this work well in high-burden settings. Next slide, please. So while we need to perform a lot more tests to close the gap, we do need to keep in mind resource constraints, especially in the current situation. We need better funded programs and we need well-priced tests. This is an example of Nigeria, which shows you a funding gap of more than $1.1 billion. And you can see from this that the main gaps are in diagnostics, mainly in the individual cartridges. So irrespective of intent, ambition, previous progress, funding is what is the biggest contributor to the gap, to the diagnostic gap in Nigeria right now. But again, on this note, I do also want to acknowledge the impact of recent shifts in international funding on TB programs, given the current USG administration's withdrawal of foreign aid, and also similar moves to cut official development assistance in countries across Europe. So while this is the case in Nigeria, we know that a lot of countries might be and will be facing similar situations, and we do need to be cognizant of that. Next slide, please. And again, talking about affordability of TB tests, this is a critical funding gap from the Stop TB partnership, and I've highlighted a few boxes over here, and you can see that TB cartridges have the biggest funding gap and are the biggest gap in diagnostics. Again, this was mentioned by Mangala in the first webinar, but this is a technical briefer from MSF Access Campaigns on the Time for 5 campaign, which shows you that when Danaher reduced the price of the expert cartridge from $10 to $8 after a lot of public pressure from the campaign, this $2 price reduction by Cepheid on the standard TB gene expert test showed us an actual reductions in prices projected, and the Global Fund said that they were saving $32 million, which could lead to procurement of an additional 3.6 million expert TB tests per year. So while we know that yeah, we know that if we have tests that are more affordable, this is a gap that we could close and have more frequent testing be done with more affordable tests. Next slide, please. So some of the key themes I touched upon in this presentation were trade-offs and considerations, mostly have to do with access. We're talking about sample types, and with sample types, we need easily accessible sample types. And this could be, over here, we're talking about oral swabs, but this could be urine, blood, stool. And these accessible sample types should be prioritized for new diagnostic development. And we know that despite lower accuracy, they do increase yield, and that is something that could massively help in closing the TB diagnostic gap. And with use cases and diagnostic placements, we need point of care or near point of care placements in community and primary care setting where people are first presenting to care. And this can enable same-day testing and treatment. And while we talk about point of care, we need to also ask what about self-sampling and self-testing? And is this something that could be possible for TB? And similarly, what should follow on DST look like in practice? Grania spoke about network optimization. So where should these rapid molecular DSTs be placed to minimize sample transport delays and minimize loss to follow-up? And to end on funding, we need well-funded TB and primary healthcare programs. A lot of these tests can detect multiple diseases at the same time. So we could push for disease testing integration so that the burden doesn't fall entirely on national TB programs. And it also makes care seeking for the end user much more easier, much easier to navigate, not that it's ever easy to navigate. And lastly, we do need cheaper tests, and we need tests that are scalable and tests that can be incorporated in low and middle income countries and high burden settings. Next slide, please. So I just wanted to point out that Treatment Action Group has the 2024 diagnostics pipeline, TB diagnostics pipeline report, and the links out over here, but it goes over all of the different TB tests in the pipeline and kind of touches upon some of these trade-offs and considerations. Thank you. Happy to answer any questions.
Thank you. Thank you so much, Teju. Okay, so I know that was a lot of information, but again, as I said earlier, this is such crucial information, as we move forward with how do we want to take this work forward. So can I just remind you again that we have a Q&A box on your Zoom screen where you can type in your questions. We will have time to answer them. Additionally, the panelists will also be answering the questions live as we speak. So as you were listening to Teju, if you had any questions or even just points of clarification, no question is small enough. It will be good for you to put it there so Teju or the other panelists can answer them. And on that note, moving on to our third speaker, Dr. Mahfuzur Rahman, who's from the Interactive Research Development IRD Bangladesh. He's the Chief of Staff at IRD, who do extensive work in Bangladesh around TB. Dr. Mahfuz will speak about the current TB diagnostic landscape in Bangladesh, including some of the challenges and opportunities. Now, the earlier two speakers have shared with you a broader information around TB diagnostics and what's in the pipeline, what are the trade-offs. Dr. Mahfuz will now take you into a more specific country context in Bangladesh. And we think this would be really useful because a lot of countries in the region are probably facing the same kind of challenges and opportunities. So while you listen to Dr. Mahfuz, it will be good if you could also already either share in the Q&A box about whether or not you're facing similar difficulty or challenges or opportunities in your countries, or you can park the question and then when it's Q&A, you could share it with the wider audience. Over to you, Dr. Mahfuz.
Thank you, Mangala, for the nice introduction, and thank you for having me here today. Next slide, please. So Mangala has already said what I'm going to talk about in this presentation, but to begin with, let me quickly take you through the current TB scenario in the country. So Bangladesh is one of the 30 high TB burden countries. It is estimated that each year approximately 380,000 people get ill with tuberculosis. In 2023, approximately 301,000 of them were diagnosed, leaving a detection gap of 21%. And among the detected, only 4% were childhood TB, way less than the WHO estimate of 10%. Similarly, 45% of the estimated DRTB patients in the country were missing, which leads to, a spread of further DRTB patients. So the picture on the right, the image on the right, it's taken from a Global Fund Quarterly report from 2022, highlights the districts in Bangladesh where with the most missing cases. This data has been crucial in guiding the molecular diagnostic placements as Bangladesh expands their molecular diagnostic capacity. I thought since we are talking about the diagnostic network and all of this image would be interesting to have a look at. Next slide, please. So the National Tuberculosis Control Program in Bangladesh operates in a 4-tier diagnostic network. At the top is the NTRL, National TB Reference Laboratory, which is based in Dhaka, the capital of Bangladesh, which serves as the apex body for the TB laboratory network in the country. It has all the specialized TB testing facilities. It monitors the quality standards across the country, and it oversees 4 RTRL, which is the second tier of diagnostic network, which are strategically placed at 4 divisions in the country to decentralize the specialized testing and support peripheral laboratories. So when I say specialized testing, of course, it means culture, LPA, DST, always. So then there are 39 EQA sites placed across 39 districts. They are there to ensure the quality and reliability of the diagnostic service, TB services. At the lower tier of the peripheral labs. These are equipped with the molecular testing and microscopy facilities. So many of you may be unfamiliar with the Bangladesh Administrative Division and District that I've been talking about. In the next slide, we'll clarify you how this level is structured. Next slide, please. So here you can see the administrative structure of the country. So the country is divided into 8 administrative divisions, which are further segmented into districts, sub-districts, and the lower tier, the unions. This slide illustrates the distribution of the TB diagnostic facilities across these tiers. So culture, DST, LPA, all these specialized tests are available only at the divisional level, the NTRL and RTRLs. Some of them are available at the private sector as well, but today that's not our focus. I'm going to talk about the NTB structure only. So at the divisional level, up to the divisional level, these specialized tests are available. So moving down next, at the district and sub-district level, you will find the molecular diagnostic and digital chest X-ray. So over the last couple of years, Bangladesh has significantly expanded its capacity in TB diagnostics with 735 GeneXpert machine, 150 of them being 10-color systems, and 150 TrueNet system placed at 750 sites up to the sub-district level. So at the sub-district level, at least one facility have at least one of the molecular tests are placed in each sub-district level. Then there is digital chest X-ray. Similarly, you will find digital chest X-ray at the sub-district level as well. But when we come to the next, the lowest level of administrative tiers in the country, the Union Parishad, which is the community level kind of thing, the only microscopy is available there. So at the NTB diagnostic algorithm recommends that all TB presumptive, Bangladesh NTB diagnostic algorithm, of course, recommends that all TB presumptive cases should undergo molecular testing as the initial test. However, due to some accessibility challenges, resource constraints, many people are still being tested with microscopy, leading to underdiagnosis and missed TB cases. I will be talking about this in my next slide. Next slide, please. So one of the biggest challenge, like my previous speaker said before, that shortage of cartridges or unavailability of budget to test all the presumptives. So Bangladesh estimates that each year we need to test 3 million presumptives, but the NTP budget only allows for 1.8 million molecular testing. That leaves about 40% gap in testing, which is then complemented by microscopy. So microscopy is very less sensitive and it misses a lot of cases. Then again, we don't have the child-friendly diagnostic as well. So stool testing is happening in the country. Rania Teju already said that stool is very low sensitive, and it's also process heavy. So we are missing a lot of child TB cases as a result of that. Also, this molecular level testing requires high maintenance and infrastructures. So it's not possible to place, although we have a lot of, as I said earlier, the 735 expert and gene expert and 150 net TrueNet system, we cannot place them at the union level or at the point of care level. So patients are, some patients who are unable to visit the net site or due to the complexity of the sample transportation system, again, they have to, they have to be tested with the microscopy, leading to more missing cases. So next slide, please. So this brings us to the next potential optimization strategy that's more suitable for Bangladesh context or similar context in the other countries in this region. We need to adopt some of the point of care tests that Rania and Teju said earlier. This has to be easy to use, can be used at the patient doorsteps, and can be used for mass screening at the community level. So several promising TB diagnostics are in the pipeline. I find mostly these three are very promising, and it kind of solves the process complexity around the sputum collection that Teju already mentioned. So AI-based digital stethoscope, the TB-LAMP testing, and proteomolecular test using tongue swab or point of care test using tongue swab. So I know these tests have lower sensitivity compared to the sputum-based test, but these are far better, far superior than microscopy. And also, if the cost is lower, we can do a combination of this test to improve kind of the pool sensitivity. So if one tool is sensitivity is around 70 to 78%, if we use these one or two point of care tools as a like a combination of screening tool, the screening the sensitivity should increase considerably. So this is something we should think about. Of course, it involves the costing, but I'm sure given the cost that the molecular testing cartridges have currently, a combination of one of two or perhaps three tests with this point of care low cost test, we should get better results. Then again, these tests don't have DST capability, so we need to also optimize the sample transportation system as well, at least up to the sub-district level where the 10-color machine are currently being placed. Additionally, like Rania said, multi-disease screening platform should be integrated or placed at this measure. So this makes the diagnostic more efficient and sustainable for the country program perspective. Next slide, please. So as a civil society member, we have some responsibility. We should push the NTP to allocate funding for adopting these newer TB diagnostics. We are the people who work most intimately with the communities. We should also work to mobilize the community voices as well as to increase the demand for this modern test. And the next step, we should advocate NTB to involve civil societies in the monitoring system, which is crucial to ensure the accountability. And lastly, we need to engage private sector to adopt these tools, manufacturer further to reduce the pricing, and research institutes to further improve the effectiveness and keep researching to develop newer tools. Thank you for your patience hearing. This was my last slide, and I am happy to take any questions. Thank you.
Thank you. Thank you so much, Dr. Mahfuz. Yeah, I think your earlier slide was so important for us to reflect on, because one of the things we have noticed so much is that, yeah, we have to increase our advocacy, but then the knowledge building part is also so important, because you cannot demand for something that you don't know about, right? So I think that is what we're trying to do by increasing the literacy around TB diagnostics, and the fact that it doesn't always, how do we break the technicality of it in order for our civil society partners to be able to push for it, by having a clear understanding of what we're pushing for. So thank you so much for that. Again, I encourage you to put your questions on the Q&A box, but also to raise your hands, so we can together share. Hang on, let me just get off the so that we can together share any. I'll just give you a minute to think about your questions and raise your hands. In the meantime, I would like to call on a few of our partners from the region to, again, because so far we've heard from Bangladesh, but we thought it'd be good to hear from other countries who have the experience having worked on the ground around TB diagnostics, on what are some of the challenges that they face, and what are possibly some opportunities that we can tap into. And if I may, can I call on Kim from SCDI Vietnam to share the situation in Vietnam? Kim, are you there? Right, while we wait for Kim, I think there's a question for Dr. Mahfuz in the chat box. I will read it out, and then perhaps Dr. Mahfuz can take this opportunity to answer it. I think Kim is trying to speak. Cassidy, would you be able to unmute Kim?
Hi, can you hear me?
Yes, now we can hear you, Kim. Go ahead.
Okay. Yeah, thank you, Mangala. Thank you, presenter. I think we also share the situation in some gaps, like Bangladesh college, just sharing and so because SCDI work very closely with the community people, so we would like to share some gaps in terms of the community and also the community system. So so in Vietnam, in terms of the gap regarding to the community, we also found that the of the TB knowledge and symptoms, especially among the people living in the remote area and ethnic minority, and this can lead to delays healthcare seeking, and especially the TB diagnosis services, and because due to the fear of the loss of working time, the income, and or financial stability, and also for some people who don't speak King's language, so the language barrier is also the big barrier for the ethnic minority people, and even though that the social health insurance cover most of the TB services, but for the poor people, they also cannot afford the paraclinical test services before being diagnosed with the TB. And yeah, and as you may know that we in Vietnam, the national TB program is conducting the community screening campaign in the whole of the country. But with the cases that cannot be diagnosed at the community screening campaign, they may be lost to follow up due to their lack of knowledge and combined with the barrier in terms of the geographical transportation and financial barrier. So you can find this is the lead to the missing case in Vietnam in terms of the diagnostic aspect, and also in terms of the community system. We in Vietnam we lack of engagement of the community-based system or CSO, especially for the group affected by TB. Currently, the community activity primarily relies on the mass organizations such as a women union, youth union, and farmer association, etc. And the community network supported by SCDI has only been involved in the last 3 years. So and we only are working on in a few provinces. And so and in terms of the national TB program, we also share the similarities gap with the Bangladesh, and we observe that the national TB program is has made a big effort on the diagnostic field. Now the expert machines, we have the expert machine in all the province, but only at the provincial level. So not everyone can access to WRT testing, and we also have the issue with the sample transportation because of the funding, because of the costly, because of the staff, the health staff implementation at the very low level. And we also had the limited testing capacity for certain drugs. You can see in the report of the TB report of the country, and in terms of the screening for the diagnostic screening for the pregnant woman, we is not adequately addressed. And so just some main point I really want to share with you. Maybe we can share more during the workshop in Hanoi next month. Thank you, Mangala.
Thank you. Thank you so much, Kim, for sharing with us. Yeah, I think that kind of analysis is so important for us to know what is it that we're facing. And yes, we can talk more about this in Hanoi, because there are a lot of similarities in a lot of our countries in the region. Just before I go to the next person who would be sharing the country experience, I just want to address the question that we had earlier for Dr. Mahfouz in the chat. Hang on. Okay. Did I miss that? You articulated a few potential use case for the new near point of care test in Bangladesh. Which is the most compelling in your view, and what evidence do you need to see to make that determination?
Thank you for the question, whoever it is. As I said in my presentation, all these three tests look promising for me. So far, what the information that we got, they are faster, suitable for mass screening, and will help reduce the reliance on microscopy. However, to finally determine which are the most compelling option for the country, we need to assess their sensitivity and specificity compared to their operational feasibility in lower tier facilities, how much technical expertise is required to operate these, and of course the affordability, the cost issues. So if the cost is very low compared to the cartridges, we can, like I said, we can do a combination of this test. Which can increase the pool sensitivity much higher. Yeah, thank you.
Thank you so much, Dr. Mahfuz. I have another partner from Mongolia, Ganzo from the Mongolian Anti-TB Coalition, who would share with us a little bit more about the challenges and barriers that is faced by Mongolia. Ganzo, would you be able to put up your hand so we can unmute you?
I'm already unmuted.
Perfect. Over to you, Ganzo.
Thank you, Mangala. Hello, everybody. My name is Ganzo. I'm from Mongolian Anti-TB Coalition. So at first I want to just, maybe some of you don't know about Mongolia, so I want to paint some picture about Mongolia. So we are living in a 1.5 million square kilometer area with only 3.5 million people. But half of the population lives in the capital city. So we have lots of other climate problems like air pollution and other stuff. And with the TB, Mongolia is one of the high burden country with the TB and MDR TB. So we have like 14,000 estimated yearly cases, but we only detect 20% of them. So obviously there's a gaps in between that to detect the people and treat them. So one of them, the main gap is that we don't have any diagnostic equipment, tool, or human resources in the point of care, especially in the family healthcare centers, in the primary healthcare centers, and because of that, we could lose most of the people to go to the district level facilities. With the Global Fund support, we have district and province level lab capacity to with the GeneXpert, with the CAD X-rays, all of that. But the screen, we have active case finding with the community, with the community members and civil society organizations. But there's a lack of management and coordination between the communities and the district level, province level facilities to do these active case findings with the information sharing and the data availability, and of course the human resource shortages, because we have like a few people living in Mongolia, and also we have only like 300 people working in the TB field. So we have lots of human resource shortages. So, and also the government procurement system is really hard to it's really hard to reach from the community, community-based organizations or civil society organizations, because there's lots of process to get funding from the government, and the global funding goes to the principal recipient is the Ministry of Health, and to get the funding from them is going through lots of processes, tenders, and it's really hard to get if you are a small civil society or community-based organization. So basically, there's the funding issue, there's the human resource shortages, and the lack of point of care diagnostic facilities. I think this is the main barriers of challenge that gets Mongolia.
Thank you. Thank you so much, Ganzo. Yeah, I mean, I think you summed it up quite well. And if we look at the similarities between all the countries in the region, there's that whole issue about accessibility, whether it's caused by cost or it's caused by geography, it's caused by information, awareness, and what is, the latest in the diagnostics landscape. These are the main things that we face. And as civil society, how do we, bridge this gap about and shape our advocacy? So thank you so much for sharing that, Ganzo. I do have a few questions from the participant, but before that, I also just want to check if there's anyone who wants to raise your hand and ask a question or share your thoughts or experience with the audience before I move on to the questions that I have here. Anyone? You can click on the raise your hand interface in Zoom. If you don't, I will ask some of the questions that have been raised. Okay, I'll do that then. One of the questions that has been asked is, what kind of rapid diagnostic tool, like the COVID-19 testing by RT-PCR, can be effective enough to cover a country like India, which is a mass country? Over to Grania or Teju on this one.
Yeah, so I think the current tools in the pipeline are, as Teju showed in her slide, the kind of near point of care tests. So they are not quite the sort of rapid antigen tests that we've seen for the COVID-19, but there is work on those kind of very, very true point of care tests, potential for self-testing. So there is work being done in the pipeline to see if those kinds of tests could be developed for TB, but there isn't anything kind of coming that close in the pipeline. Some of the considerations, I think, particularly thinking about tongue swabs, is there is sort of what is the potential for doing mass screening campaigns with tongue swabs, and then potentially using more centralized high throughput machines to be able to run many, many samples at high speed. So I think as we get these new sampling techniques, sort of thinking about how they could work with existing molecular tests. So kind of, as Teju was showing, there's work being done on sort of how tongue swabs work on the Expert platform, how they work on the TrueNat platform, but they could also potentially work on some of the higher throughput machines that are very centralized, which could allow for mass screening. But so I think there's lots of, it's very new, there's lots of unanswered questions, and Teju may want to add some more there, but I think let's challenge ourselves and challenge the research community to see if we can get an answer for you on that. Teju, let me know if you want to add anything more.
Yeah.
Thank you, Grania.
I agree with what Grania said, and just to add on to that, I think bringing the test closer to near point of care is probably the closest we'll get to the rapid antigen test right now. But I think, as you'd mentioned in your slides, Ganya, maybe like a urine lamb test that could be kind of like a pee on a stick kind of test that gives you quicker results could be more scalable and more rapid in that way. But from my knowledge of the pipeline, I don't know if any of that's coming at least until 2026. So in terms of more scalable, quicker options, I think right now the oral swabs, it could be the most promising ones. And hopefully we do have a self-test or self-sampling option in the near future. But especially for a country like India where you're conducting mass testing and mass screening. But I think bringing it closer to the point of care is a big step forward in that case.
Right. Teju, now that we have you, there's another question that's probably best directed at you. Are these new TB diagnostic tools that's in the pipeline already approved by WHO? That was a question that was asked.
If you're talking about the oral swab, I think there's potential for a WHO guideline development group to happen later in 2025 or maybe early 2026. So the data for this and clinical validation studies and data is being collected for this, but it's not happened yet. But I think that's on the radar and very close in the timeline. Grania, do you have more clarity on that?
I think those timelines with regards to WHO looking at the tongue swab as an alternative sample and the various platforms is coming at the end of the year. Yeah, so that's the timeline I have as well. Over.
Right. I do have another question. Are there any WHO approved point of care tests for diagnosis of TB other than the LAM? And how much do these tests cost?
I think the urinary LAM test is our only point of care test, and the indications for it are fairly narrow at the moment. So I think it's really very much focusing on people living with HIV and a cohort within that. But I think and that's why there is continuing work for the next generation of urinary LAM to see if it can kind of be a test that we can use for a wider group of people. And I think particularly kind of children and other people who are unable to produce uterine samples. Over.
Right. Thank you. And I have another question from Vanessa. I'm gonna read that out for both you and Teju. In a couple of diagnostic studies, including the ones I have been part of, people usually compare performance to WHO TPPs. I wanted to ask, though, whether WHO benchmarks should really be all and end all when it comes to having potential biomarker-based diagnostic tests move forward.
I could try to answer that, but I do think with the WHO TPPs, they're usually really robust in terms of the evidence-based approaches that go into it, and it takes a lot of discussion, experts consultation, and it really is a whole well-rounded approach where you take into consideration like civil society, communities, researchers, lab directors, technicians. So I think for now with the WHO TPPs, for example, the ones we have with I think I went over it in my presentation, but with the models that go into the minimum required sensitivity, you can kind of go into details of these models and see what is the details of it and what the trade-offs are. So in that way, I think WHO TPPs are the best we have right now for guiding such decisions and also for guideline developments. So I think that's a good way to go about it.
And I think the other purpose of the TPPs is kind of making sure that any product is developed is kind of what is needed, and that's where, as you say, the kind of multi-stakeholders with regards to kind of, is it something that the programs will implement? Is it something that WHO can give guidance on? Is it something that the communities and people affected by TB are likely to want an uptake? So I think that's the kind of other component to the TPPs, is to make sure that research dollars are working on products that the community, across the broad community in TB, want and will be able to use.
All right. Thank you, Grania. I have another question. I've been like holding off to this question because I'm not sure if any one of us will be able to answer this, but I'm going to read it out just for us all to see, you know, if we can answer this question. How will Trump's aid policies affect USAID's TB support in Asia Pacific? I know this is a tough one, and I'm not sure if any of us have like an absolute answer. But if anyone feels like they want to have a go at this, please.
Hi. So
Hi.
this is a
Go ahead,
this is a
Shannon.
tough
I know.
question. Hi, I'm
I
Sharon
know.
Ann Lynch with the O'Neill Institute. So USAID has been on the target list, unfortunately, of the Trump administration and their efforts to outright dismantle it. However, the TB program within USAID continues. It continues at a much lower capacity than what it had, and its future is unknown. You all know that while some grants were terminated and then that termination was reversed, that is only for the existing life of the grant, and there are still many unknown answers in terms of the future. So that is still up in the air. We hope, and there are a number of people pushing for corrective action. There are court cases every day, and new news breaking last night that while some members of the Trump administration do not have the right to dismantle USAID, to block employees from the building, from their email, etc., that others in the administration do. And that includes Secretary Rubio, the current Secretary of State. So we hope for the best and need to prepare for the worst, because already on the ground, so much has been happening and with services curtailed. This includes USAID's support for essential commodities, including diagnostics. So while USAID had been a champion for expanding capacity of TB diagnostics in countries, especially those hard hit by TB, drug-resistant TB, we don't know what will happen in the future. Obviously, in addition to maintaining treatment for those that started, to be able to continue new treatment initiations, we obviously are on this webinar because we believe that diagnostics are a priority, not just for monitoring treatment, but for as well detecting new cases, including cases of drug-resistant TB. So I'm sorry, I don't have a real answer for you other than fear and rage and whatever hope that we can muster. Back to you, Mangala.
Thank you. Thank you, Shannon. Yeah, I mean, that's a tough one, but yeah, but I guess that's again is a reminder to all of us that we have to continue working on it, because while some things are uncertain, the fact that the TB will not stop is a very real one. And on that note, do we have any other questions? Anyone wants to share one final thought before I wrap
Mangala, do
up?
you mind if I share another thought?
Please go ahead.
So because of USAID and the stepping back that was not of their own choice, this makes efforts such as the Global Fund and those by national TB programs that much more important. So we look to this regional TB meeting, and I put some information in the Q&A about it, that is convened by WHO, KNCV, Global Fund, and UNIDAID, I believe. That much more important, because national TB program managers will be asked a few things. One, are you in accordance with the treatment guidelines that have come out from WHO, both for drug-sensitive TB, which is an easier answer, but also for drug-resistant TB? Secondly, are you in accordance with today's recommendations from WHO regarding TB diagnostics? Obviously, WHO, as you've heard, they recommend the current molecular-based diagnostics for testing TB, rather than just relying on symptoms, or rather than relying on microscopy, given its weaknesses as have been outlined. But also the Hanoi meeting, and especially the day that is being run by Global Fund, is an opportunity to look at the pipeline. So these tests that are emerging and the questions that should be asked together as a TB community, as Grania said, in terms of, do they meet the needs? Do they meet the local needs at the primary healthcare level, secondary level, etc.? What we hope to get from this meeting as civil society, and this is a meeting that we've looked forward to, is to start to get some ambition in terms of what the NTPs say that they're willing to do and want to do, but also accountability. So given that these new tests hold a heck of a lot of promise in order to fill these huge gaps in TB testing, we would like to see NTPs commit to developing roadmaps. That is, what are they going to do to prepare? What are they going to do to get the answers to some of their questions? And then, given you've seen the timelines both from Grania and Teju of when the test will be available and or recommended by WHO, then what does activation look like? And what does it mean in terms of what tests where? So, and what are the goals of government? And one of those measures of goals could be in the form of facility coverage. So if they determine that one of the near point of care tests would be suitable for the settings and should be at the primary healthcare level, then what percentage of the primary healthcare facilities do they mean to equip, to capacitate with these new near point of care tests within the first year, within the second year, within the third year? And the more that we measure, the more that we can hold governments to account. In addition to hopefully watching the number of new cases detected, we want to see that the capacity issue as well. Back to you, Mangala, and thank you for letting me butt in.
Thank you. No, thank you so much, because that's really important, because one of the things that we want to do is that how are we building this case from now to Hanoi and beyond? So I think one of the things, at least I have realized in this past two webinars, is the fact that we have to continue to increase the TB diagnostic literacy in the region, and figure out a way to bridge the gap between like the research fraternity and the civil society and those who work with the TB affected communities and the community themselves, because we need to sort of capitalize and cross-learn from each other in order to be able to either support or advocate with the NTPs, and even to hold them accountable. So I do hope that we've set the ground for that, and as we move to the PrEP meetings to Hanoi, we're better equipped to do that as a collective. So thank you so much to everyone and to the panelists, all the three of you. I know